Hello, my name is Cynthia Robinson. I'm a nurse practitioner, and I'm currently a DNP student at Maryville University. My project focuses on utilizing a diabetic foot template to implement new referrals in a federal qualified health center. Before I begin presenting my project, I would like to recognize my committee. My chair, Dr. Jessica Bland, has provided invaluable guidance and leadership throughout this process. My second reader, Dr. Snell, offered thoughtful feedback and expertise that strengthened my work. And my community member, Dr. Phyllis Thompson, contributed important insight and support. I am truly grateful to each of you for your time and commitment to my academic journey. My project focuses around a vulnerable population, which is the diabetics, and its complication. And my project is going to focus on one intervention that can decrease this complication, which is increasing foot referrals. Diabetes is a growing global health concern, with foot complications posing serious risks and driving healthcare costs up. The academic project focused on a FQHC use of a comprehensive foot template, which has previously been applied only partially in nursing workflow, which has resulted in foot complications, hospitalization, and poor outcome. The purpose is focused on increasing referral rates by fully integrating the template into the electronic medical record system to improve accuracy and consistency. By standardizing documentation, the project aims to increase referral rates, thereby directly reducing long-term complications, decreasing healthcare costs, enhancing provider-patient communication, and ensuring timely intervention. This strategy ultimately strengthens prevention efforts, lower costs, and enhance organization funding through improved quality metrics. Why is this strategy significant not only to primary care but to healthcare as a whole? Provider and staff in specialty areas such as emergency medicine, cardiologists, endocrinologists, and others may ask question, why is this important to me? Or they may assume that foot ulceration prevention does not directly affect their practice. In reality, it does. Primary care role is prevention and is really critical, and their focus is in prevention, ensuring that patients receive evidence-based resources, healthcare, and guidance to support effective workflow and proactive care. A little background about myself. My background consists of ER trauma nurse. I have witnessed firsthand how untreated foot ulceration can escalate into serious complications such as sepsis and cellulitis, often resulting in emergency amputations. Beyond the emergency setting, foot ulceration is closely tied to peripheral vascular disease, a cardiovascular condition that significantly increases the risk of heart attacks and stroke. Endocrinologist plays a vital role on focusing on blood sugar management, which is essential for wound healing and decreasing foot complication. This demonstrates that foot ulceration prevention is not only confined to primary care, but it is a shared responsibility across the healthcare organization. The literature review was conducted using credible resources including the Maryville University Library, Oversensities, the American Diabetic Association website, and the CDC. Evidence highlights the importance of utilizing multidisciplinary approaches such as using specialties and other tools. The use of a dermal In one of the literature, one of the use of a derma regeneration template has shown to improve wound healing and promote wound salvage. The ADA recommended annual foot examination that should include inspection and sensation testing to reduce morbidity and mortality among diabetic patients. Clinical findings demonstrate that routine foot exams significantly decrease ulceration infection rates by 50 to 65% and amputation risk by 20%. Yet only 46% of diabetic patients reported receiving comprehensive screening in primary care settings. Implementations of the EMR, the foot template that's embedded in the EMR, has been proven to improve compliance and accuracy of annual foot exams by 31%. In another literature, it shows that documentation within the EMR use further support early recognition, accurate referrals, and continuity of care while enhancing staff productivity, reduces bias, and minimizing incomplete charting. In other literature, it shows the significance of minimizing the complication. It shows that diabetic affect 537 million individuals, with 34% at risk of foot ulceration and reoccurring rates reaching to 65% within 3 years. In the U.S., treatment costs exceeded $245 billion in 2012, with $9 billion contributing to foot ulceration. Overall, the literature demonstrates the combining structure template, the EMR system, and the ADA guidelines can lead to accurate assessment, early referrals to improve the outcome of this vulnerable population. So the Kurt-Lewis change theory helped guide this project. And this theory was chosen to assist with resilience to change flow within the nurses and staff that's using the template. The Kurt-Lewis change theory consists of unfreezing, change, and refreezing. The unfreezing is what we have to do to unfreeze what is not working in the clinic. So this unfreeze in this section, it raised awareness that free text documentation and partial use of the embedded template are inconsistent and often incomplete, resulting in decreased referral rates. The shared evidence that was shown in the prior slides shared evidence showing a structured template improve accuracy and patient outcome. Next comes change. There have to be the ability to change. The utilization of the template is part of the change process. And in order to change, we did training, and then we did some support resources, which using the American Diabetes Association. This promoted a smoother transition to decrease the resilience. Refreezing. This is showing that the template that's embedded in the EMR system can monitor referral quality and reinforce success through feedback and recognition to make the practice permanent. This project used a retrospective pre- and post-intervention design, meaning patient records was examined before and after the diabetic foot template was introduced to determine whether it increased increased referral to specialties. Several methods was used in this project to ensure effectiveness. Patients were screened during predefined inclusion and exclusion criteria to ensure valid and reliable results. Specifically, only individuals with type 2 diabetes age 30 and older was included, while those with unrelated condition was excluded. The foot screening template was modified and aligned with the American Diabetes Association guidelines, providing an evidence-based framework that supported providers to apply best practice and utilize up-to-date resources. Patient confidentiality was a safeguard through the project by using the electronic health records, therefore maintaining privacy, trust, and adherence to ethical standards. To strengthen the implementation, staff was trained on the proper use and importance of the template. They was also given the opportunity to show any concerns of why the change is not feasible into their practice. This ensured consistency in the practice. Also, poster was displayed to raise awareness. This actually improved the staff engagement, prepared patients for foot exams, thereby reinforcing the value of consistent foot screening to increase the referral rates into the clinic. After consultation with the statistician, a sample size of 154 was identified as significant to minimize error and strengthen the value of the findings. The study population includes diabetic patients aged 30 and older with the A1C of 6.5. So the A1C is the average of a person's blood sugar over a 3-month period. So this looked at a patient that's greater than 30 and had an A1C of 6.5 or greater. Exclusion criteria applied individual exclusion criteria was applied to individuals with double amputees and those had already referred to specialists. This approach ensured that the sample focused on patients who was at most risk for foot amputation while maintaining eligibility for preventative intervention and referral. In this project, descriptive statistics was used to analyze referral rates over a 10-week period, with data managing using statistical package for social science and Excel. The SPSS was used to determine what percentage of patients who met the inclusion criteria was referred to specialists. Descriptive measure captured the accuracy and promptness of referral. The variables included was independent and dependent. The independent variable was the foot template, while the dependent variable was the referral rate. To evaluate the impact, a upper tail z-test was used for the difference of the two proportions and was applied to compare pre and post intervention. So the two proportions was pre and post interventions. The findings were highly significant. The statistical power was 0.999, reflecting a very high probability of detecting a true effect and confirming that both the sample size and the effect size was sufficient for a reliable conclusion. The p-value was less than 0.0001, providing a strong evidence that the template produced meaningful change, with referral rates highly likely to increase if the template is used promptly and consistently. The confidence interval suggested a true increase in diagnosis between 16.1% and 38.4%, which is important because the zero was not included, confirming the effect is in one direction and showing a clear rise in referral post-intervention. So this is looking at, it is a one-way direction showing that in the post-intervention, the referral rates is likely to increase. So it's showing that this has a significant value. The effect size of 0.586 demonstrated a strong impact of the template, emphasizing its importance to improve referral practice and strengthen the diabetic referral rates. There is significant evidence to suggest an increase in the ratio of referral from pre to post intervention, with the referral rates rising above 27%. In a project, it's important to address limitation and to identify them. In this project, there were several limitations that was important to acknowledge. First, it was conducted only on individuals with type 2 diabetes, age 30 and older. And what does this mean? This means that the finding did not apply to younger patients or those with type 1 diabetes. That produced some bias as far as only looking at type 2 diabetes is a high-risk population and not type 1 diabetes. Second, this study was limited to 10 weeks in a 10-week period. So while the results were significant, they reflect only short-term outcome and may not capture long-term trend to support the sustainability of the project. Finally, the project was carried out in a single clinic setting, which constrict the generalizability of the findings since within the practice. Patient population and resources may differ across other settings in healthcare system. Recognizing these limitations help place the results in context and highlight the result for broader studies to strengthen the evidence. So you can see the foot template led to a significant increase in referral rates, rising from 7.87% before the intervention to 35.14% after fully utilizing the template. These results align with the American Diabetes Association recommendation, which emphasizes routine foot exam and timely referral is a critical component in diabetic management. By demonstrating that the template can improve adherence to the evidence-based guidelines, the project highlights its value in strengthening clinical practice around other settings. While the findings are promising in future direction, including expanding the use of the template to additional clinics, this can access its impact across diverse patient population and extending the study period to evaluate the long-term stability. Together, these steps can help determine whether the template can serve as a scalable, reliable tool for improving diabetic foot care through increased referrals. In practice, this project highlights several important implementations. First, it shows that the value of consistency in implementing quality evidence-based guidelines across healthcare settings, which ensure that patients receive standardized and reliable care. Second, it emphasizes the need to strengthen providers' training in cultural sensitivity and communication with patients who has limited health literacy. This is critical because patients often struggle with understanding medical terminology like what is preventative care or what is taking a proactive approach. Adding these cultural communication to the clinical setting helps bridge the gap. Also, the project demonstrated that a structured workflow can improve outcome across the vulnerable population, ensuring that the care is not only effective but also sustainable. The DNP project was initiated due to the rise in due to the rise in low referral rates and increasing in foot complication. This clearly showed that the need for preventative strategies. By utilizing the embedded foot template within the EMR system, referral rates rose from significantly from 7.8% to 35.14%, demonstrating it is very effective. The template provides consistency, reliability, and functionality, and was guided by credible literature and resources recommended to ensure evidence-based practice. Importantly, the tool is scalable across healthcare settings of different settings and expansion in its use to other clinics and also to a broader population, not only to type 1 diabetes, but also in the not only to the type 2 diabetic population, but also to the type 1 diabetic population. Overall, the template strengthens referral practice, closes the gap, and support better outcome in diabetic foot care through the increase in referral rates. Thank you. And the following slides is showing my reference for any further research on the research that I did for my DNP project. Thank you.